I'm Dr. Ken Anderson, and I'm here at Myeloma 2015. Once more this year, the progress is palpable in many areas. We've had continued progress in some of the drugs that we have had over the years, the proteasome inhibitor and immunomodulatory drugs, but many advances in genomics, epigenomics, understanding the disease better and addressing it with entirely new classes of novel agents. So we're going to just summarize today, and I must tell you first that I'm honored to be joined by Dr. Jesús San Miguel from Spain and Dr. Antonio Palumbo from Italy, clearly world leaders in myeloma research and clinical trial research for decades, literally, to discuss primarily how are we going to combine and optimally use some of these novel therapies. There was a session at the Myeloma 2015 meeting where Dr. Orlowski and Paul Richardson and others talked about, Dr. Jakubowiak from the University of Michigan talked about, we have this literal candy store of novel agents, not only the immunomodulatory drugs and the proteasome inhibitors, but now we have monoclonal antibodies. And they talked about how, in real terms, this might be used to treat our patients. So, Jesús, do you have any thoughts about where we are and what the future is with all of these new agents?
Okay, as you have beautifully summarized, we have now the second and third generation of proteasome inhibitors and immunomodulatory drugs, carfilzomib, ixazomib, marizomib, and we have also pomalidomide. And these reagents have shown the capacity also to be useful in patients that had failed the first generation proteasome inhibitor and immunomodulatory drugs. And therefore, the next step is just to move these drugs into the front line. And on top of this, we have drugs with novel mechanism of action. By sure, the monoclonal antibodies are on the top, but we have also the HDAC inhibitors that has a completely different mechanism of action. And the other immunomodulatory drugs, the immune system is also a target in the immunocheckpoint. Mm-hmm. Therefore, I think we have now, as you have said, many drugs, and the next task is to use them in the most appropriate way.
Yes. And Antonio?
No, I completely agree with what has been said until now. I think to make it more simple, we basically have IMiDs, and we have been seeing the first, the second, and with pomalidomide, the third generation IMiDs. We have proteasome inhibitors, and we have been seeing bortezomib, and then also we will have ixazomib, that is the oral counterpart, and carfilzomib, that is the second generation. So we have a second class. And now is coming the third class that has basically all the monoclonal antibodies. So for the future, I completely agree with what has been said by Jesús. We will have to learn how to sequence, but probably the combination will be including a monoclonal antibodies with an IMiDs or a proteasome inhibitors, and this will represent the backbone of the future treatment. Today, we still have both, right, IMiDs and proteasome inhibitors.
No, and I think one of the things, Jesús, that you've sort of led the world in, one of many, is now that we have these novel agents and they're well tolerated, we can use them in combination. We can define what's optimal in terms of efficacy and tolerability, but then we can move them earlier and earlier into the disease course, and you've been pioneering the studies in smoldering myeloma in that regard.
Yes, but sure, as soon as we treat the patient, the highest the chances that we have just to cure this terrible disease. And I think this is an area that is going to be also explored with the new monoclonal antibodies and the oral drugs that will facilitate the treatment in early stage of the disease.
Yes. And I think the other thing just to mention, so one is that we have better therapy for active myeloma. We are extending the spectrum of patients who can hopefully benefit from therapy and maybe have better results than ever before. But then on the other end is the idea of maintenance. And we've been using oral lenalidomide, but now we are an oral proteasome inhibitor that will be here soon, and we have monoclonal antibodies, maybe HDAC inhibitors. But there's going to be options not only early in the disease course and for active disease, but perhaps for better maintaining the responses than we've ever had as well. So let me just focus. My favorite area for the future is immune therapies, and in particular combinations of immune therapies. And we had a very lively and a hugely exciting session this year around immunotherapy. The checkpoint inhibitors in melanoma and lung cancer have achieved remarkable responses, but I think in myeloma, we are also poised to appreciate another paradigm shift when we incorporate these. So we had talks about vaccines, we had talks about checkpoint inhibitors, we had an expansion on the detail of monoclonal antibodies, and then honestly, to me, maybe the most exciting of all, I think they'll end up being combined, but maybe the most exciting thing of all was the CAR T-cell presentation. But what are your thoughts about the future of immunotherapy in myeloma?
Okay, I think that the first evidence of the value of immunotherapy we had with the allogeneic transplant. When you infuse active T and NK cells, you are able to control the disease. Then now probably we need to understand better the defects that we have in the patient on the T and NK cell function, try to repair that. And now we have probably the opportunity of using drugs that can help on this together with the vaccination. Probably is going to be again a revolution. We have just recently heard about Hodgkin disease that is responding pretty well to PD-L1. In multiple myeloma, probably we need combination, as you have mentioned, for the immune system.
Yes.
Yeah, it's certainly true. I think we have been starting years ago with allogeneic transplant that was a totally specific immunotherapy. And now I think we are on the path to learn how to use the immune system to control the tumor. And I completely agree with what has been said until now, that basically we have two major technology here. One is the antibodies that are stimulating the T function, and the other one is certainly the CAR T technology that seems very, very promising.
Yeah,
but will take some time. It's not just behind the corner.
I think it will take time, but I must say some of us have been looking for decades for immune therapies in myeloma. So this is a hugely exciting time because I think the promise is being realized. The issue that you point out, which is so important, Jesus, is combinations.
Yeah.
So here we had data updated on, for example, lenalidomide, the immunomodulatory drug with a variety of antibodies, elotuzumab, daratumumab, and the SAR CD38 targeting antibody. We heard from Dr. Avigan about combining vaccines with lenalidomide or vaccines with checkpoint inhibitors. And then the very exciting CAR T-cell talk achieves remarkable responses in albeit a single patient treated to date. But the issue is there, how can we prolong that immune response? How can we make sure there's a memory immune response? So the opportunity at least exists for maybe lenalidomide or maybe checkpoint inhibitors to prolong that CAR T-cell mediated response. So,
if I can interrupt you, I think this could be a strategy particularly valuable in early disease, in early stage of the disease. Because if you think in the MGAS or low-risk smoldering, they don't transform, they don't evolve, most of these patients. And the explanation should be in the immune system that is much better preserved. Then in the high-risk population in the early myeloma, probably to exploit the immune therapy approaches are going to be something very attractive.
I could not agree more. I think, what we heard at this 2015 myeloma meeting in the immune area is that there are responses, even at the other end, in relapsed refractory myeloma, literally refractory to all of the known agents. And so it's possible that the immune system can have a meaningful effect even with adverse genetics and adverse clonality, et cetera. But the time when it's really going to be used to hopefully most benefit is very early, when the host still has a lot of immune system and their immune repertoire is pretty normal. So, would you agree? Yeah.
Yes, but I would add something, because I think there is a balance here between two events. One is the tumor that might have a genetic mutation that transform a benign in a malignant tumor. From the other hand, certainly there is an immune system that is controlling. So I think there is a balance between those two players, and we hope that the next generation sequence technology from one side and the immune from the other side might really represent a major breakthrough in the understanding and treating of the disease.
See, one of the things that I'll mention, and we can be all proud of being myeloma physicians and researchers for a long time, but we have together as a community appreciated the importance of not only the tumor cell and the genetics and biology of the cell itself, as you say, Antonio, but we have appreciated the importance of the microenvironment, which includes the immune cells. And the immune cells are effector cells like T cells and NK cells and NKT cells, which are mediating beneficial effects, but it also includes regulatory T cells or myeloid-derived suppressor cells or plasmacytoid dendritic cells. All of these are the enemy. They're suppressing the immune system, and in many cases, in so doing, promoting the growth of the tumor. So these therapies that we're discussing are actually interrupting the growth of the tumor in this context. So they are actually overcoming those effects even of the accessory cells. So it's very exciting.
Yeah, certainly.
So,
Definitely.
so I think, I hope we've conveyed the excitement here again this year. We have been so lucky. The survival of our patients is probably threefold, maybe even longer now, extended because of novel agents. And we all believe very, very strongly that the future is brighter still.